I'm Dr. Sarah Hurvitz, Professor of Medicine and Head of the Breast Cancer Clinical Trials Program at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. More and more, we are utilizing neoadjuvant chemotherapy for patients with early stage breast cancer, either HER2 positive or HER2 negative. Although the chance of having a substantial response or pathologic complete response is quite low for hormone receptor positive HER2 negative breast cancer, we see very high rates of pathologic complete response when we treat with chemotherapy triple negative breast cancer, which is ER, PR, and HER2 negative. And so more and more clinicians are utilizing the neoadjuvant setting to interrogate the tumor's sensitivity to systemic therapy such that we can switch therapy if we're not seeing a desired response during the neoadjuvant setting. It's relatively rare that I will use neoadjuvant chemotherapy, or I'd say uncommon for ER positive HER2 negative breast cancer, unless the patient has more locally advanced disease and needs to have treatment to enable a better surgical outcome. In terms of HER2 positive neoadjuvant therapy, the standard is to give chemotherapy plus HER2 targeted therapy, usually trastuzumab, pertuzumab. And for patients who don't achieve a pathologic complete response, the standard is now to give the antibody drug conjugate, TDM1, after surgery for those patients with residual disease because of the Catherine data showing a substantial improvement in disease-free survival. Given the availability of this antibody drug conjugate, I do not tend to use standard cytotoxic chemotherapy after neoadjuvant therapy for HER2 positive breast cancer because the results were quite compelling for TDM1, and the safety of TDM1 is better than standard cytotoxic chemo. We don't have any evidence to date that adding systemic cytotoxic chemo in addition to TDM1 after surgery for residual disease is helpful. In terms of HER2 negative breast cancer, if there is a lot of residual disease at the time of surgery, there's been a few studies, one of them being CREATE-X, looking at the use of adjuvant capecitabine. And the use of adjuvant capecitabine for 8 cycles was shown to improve survival and disease-related outcomes for patients who received it. But this benefit really did seem to be primarily restricted to triple negative breast cancer because, of course, these patients don't have hormonally targeted agents to utilize. So this is where I tend to use that sort of chemotherapy after neoadjuvant. In the case where I've chosen to use a non-anthracycline-based neoadjuvant regimen, like a taxane with platinum, for example, for triple-negative breast cancer, if there's residual disease at the time of surgery, I will strongly consider utilizing AC after surgery if we didn't use it prior to surgery.